we know that there has been rapid advancement in the myeloma sphere. Can you speak to how the introduction of novel drugs, treatment combinations, and therapeutic modalities may pose some challenges for healthcare providers as they attempt to explain the sequence of treatment in relation to available clinical trials?
Yeah, that's a really good question. Especially because so many things have been changing in myeloma in such a rapid succession. It's been kind of not only an incredible transformative past 20 years in myeloma as we've moved away from using chemotherapy to using really targeted therapy, but really in the past, 5 to 10 years and us using immunotherapy and now T-cell directed therapy, it's been transformative. And it's been, very, very difficult for myeloma experts to kind of configure how these treatments are sequenced and how the clinical trials are conducted. But basically, we have gone from using single drug therapies to using combination therapies for refractory patients to using multiple, modalities in as upfront therapy for myeloma. Up until today, the us using, 4 drug induction therapies with IMiDs, proteasome inhibitors, and now immunotherapy with anti-CD38 therapy being used up front. Now we have, we're on in fact, we're past the horizon of using T-cell directed therapy for relapse refractory myeloma. Those are now being put in combinations, and at the last meetings, we saw data in combining talquetamab with the bispecific antibody with pomalidomide having, incredible response rates to 99 to 100%. The combination of using daratumumab with teclistamab at ASCO a couple years ago, having very, very, very high response rates for relapse refractory patients. And of course, the combination of using 2 bispecific antibodies, talquetamab and teclistamab together, having again these incredible response rates, and for relapse refractory myeloma. So in very quick order, we're going to see those therapies moving further and further up front, which is, a huge benefit to patients. But it can be kind of difficult to keep up with all the changes in myeloma, especially as we move from using these drugs as single agents to using them in combination. And not only to speak to, the using some of the newer drugs, like mezigdomide in combination with daratumumab, having, one of the cell mods having very, very high response rates. And so it's exciting, but it's a challenge to discuss clinical trials with patients because, so many things have changed. We now have clinical trials across the spectrum of myeloma, using bispecifics as upfront and smoldering myeloma, which was at the last ASH meeting, to using, again, more novel therapies upfront in relapse refractory space and in the maintenance therapy space.
Well, that's all very exciting. And I appreciate you sharing that because as you've said, there's been really kind of an explosion, for lack of a better word, in the numbers of treatments that are available, as well as increasing improvements and results. But as you shared, having all of these different modalities available can definitely cause some confusion, even among those who do this every day.
Mm-hmm.
Do you have anything to add to that, Ms. Gleason?
No, I think Dr. Cole, described that perfectly. It's an exciting time and also a challenging time, which just really brings you back to that team care approach to your patient and how all of us need to work hard to keep up to date on the latest information. Dr. Cole mentioned, quadruplet therapy, and, we've got 2 clinical trials that have essentially told us if you add that quadruple therapy and add that antibody up front, you drive that deeper response. So, we change our practice probably sooner in the academic settings. And it's really, how do we get this out to other healthcare providers in our referral bases that send patients to us? And then also, how do we do maintenance? And I think Dr. Cole would agree, most of us risk stratify for that maintenance setting too, whether it's one drug or multi-drug, depending on our patient's disease.